I would like to
Thank you.
invite the chairpersons for our next session, Dr. Pankaj Desai, Dr. Surinder Rana, and Dr. Sumit Bhatia. So please invite the speakers for the next session. Thank you.
Yeah. Good evening. Can you hear me?
Yes.
Yeah, I'm Dr. Pankaj Desai. And thank you, Dr. Rajesh and Dr. Sood for this invitation. And now I would invite my dear friend, Pradamche, how are you?
Yeah, I'm good. Can you hear
Yeah,
me?
yes, we are hearing you well and good. And I would like to invite Dr. Pradamche from Thailand, and he's going to give us a talk on how I do it, the rendezvous biliary drainage. So, Dr. Pradamche, please go ahead.
Oh, thank you, Pankaj, and thank you, Dr. Surender and Dr. Sumit, to be share in my session. So my talk today will take about 12 minutes, and for the EUS guided rendezvous, how I do it, and this is a video lecture. So once again, thank the organizing committee for inviting me to join this excellent meeting. So look at this slide. If you want to do the EUS guided rendezvous, I mean, certainly when ERCP fail, right? So then you try to choose another method instead of percutaneous biliary drainage, which everyone know well that I mean, short-term success rate is very good, but I mean, complications in terms of long-term maintenance is very cumbersome. So look at this diagram. For EUS guided rendezvous, you have two ways to go. The first one is the intrahepatic approach. You puncture into the left intrahepatic bile duct, and then you pass the guide wire all the way through the papilla and through the duodenum, and then you switch to ERCP scope and grab the guide wire and perform the standard ERCP step. This is the intrahepatic duct approach. The other techniques is extrahepatic duct approach. You puncture into the distal bile duct with the wider scope is in the duodenum, and then you manipulate the guide wire. Typically, the guide wire will go upward, but after manipulation with the very skillful technicians, so then the guide wire will go back to the papilla and went back and go back to the duodenum, and then you change the scope to the ERCP scope and follow the same step with the ERCP scope. So that's two techniques of the EUS guided rendezvous methods. So what's the competitors of the EUS guided rendezvous? I would call EUS guided anti-glare stenting is important competitors for EUS guided rendezvous, because both anti-glare stenting and rendezvous, they are transpapillary EUS guided biliary drainage. And the advantage of the anti-glare stenting is it is the single step procedure, and it's possible even the location of the distal bile duct obstruction and also the or to conjunction with the supraempyreal duodenal obstruction is still possible, but it needs tract dilation for both hepaticogastrostomy tract that you puncture in, and also the distal bile duct obstruction area as well through the EUS. So that's a little bit more tricky for EUS guided anti-glare stenting, but it's single step procedure. To my practice, once I need transpapillary EUS guided biliary drainage, I almost always start with the anti-glare stenting until I fail. Then I couldn't. So then I will switch to the rendezvous procedure. And that's the reason why in my institute, we mostly do the intrahepatic duct approach, because we choose anti-glare stenting for transpapillary drainage as the first choice. So then we rarely use the extrahepatic duct approach for EUS guided rendezvous. The EUS guided rendezvous disadvantage is two-step procedure, and also for extrahepatic duct approach is technical demanding for manipulating the guide wire in the extrahepatic bile duct and try to push the wire back into the papilla again. And with the extrahepatic duct approach, it's not possible with a case with the supraempyreal duodenal obstruction. Is not possible for that. So then the steps of the EUS guided rendezvous, we start with the puncture always, all procedure of EUS guided biliary drainage, and then we do need 19 gauge needle with the contrast and guide wire. And the second step is the dilation. For the dilation, if you need to pass only the guide wire into the left intrahepatic bile duct and all the way across the obstruction in distal bile duct obstruction, probably you don't need the dilation of the tract. An extrahepatic duct approach, sometimes you might need a little bit because you might need to insert some device to manipulate the guide wire back into the to the duodenum again. But if you can do without the dilation, that will be great. And for stent placement, the technique for the stent placement is more comfortable than transmural EUS-guided bleed drainage because you place the stent via the standard ERCP techniques. So the technique starting from you identify the guide wire, you might cannulate along the guide wire, or you might grab the guide wire back into the ERCP scope and then follow with the standard ERCP techniques. So this is one of my case, which is anti-glass stenting. So, but almost similar, initial step almost similar with the rendezvous and with the rendezvous with the intrahepatic duct approach. You place the scope into the upper stomach, try to identify the bile duct and puncture into the dilated left intrahepatic bile duct and pass the guide wire across the distal bile duct obstruction here. And then if you want to do anti-glass stenting, which in my institute we will try, we will dilate the the distal bile duct obstruction with the dilator. And once if we can do that, we will place the stent that we want to do most of the time, self-expandable metal stent. And for anti-glass stenting procedure, the whole procedure will be controlled with the fluoroscopic view only and no endoscopic view. But if you do need only rendezvous techniques, what you're going to do, you puncture into the left intrahepatic bile duct and you pass the guide wire and try to push the guide wire into the duodenum and finally to the jejunum and try to keep the wire inside the jejunum as long as you can. And then you extend the guide wire with the echo endoscope out and then switch to the ERCP scope. That's the techniques of the EUS-guided rendezvous. So in this case, in one of my case that I plan to do the EUS-guided anti-glass stenting, and then I identify the dilated left intrahepatic bile duct and puncture the needle in, inject the contrast, and try to pass the guide wire across the distal biliary obstruction. I can, yes, but I couldn't pass the dilator, and certainly then I couldn't pass the stent with the anti-glass stenting. So then I switched to the EUS-guided rendezvous. So what I did, I just left the guide wire here, transpapillar, and I changed to the ERCP scope. And in this case, I try to cannulate into the bile duct along the guide wire, and then I successfully got in. So then finally, I pressed the stent similar to the techniques of the ERCP techniques. So then this is another case that I tried the anti-glass stenting, but I couldn't pass the guide wire and the dilator through distal biliary obstruction. So what I did, I pressed another hepaticogastrostomy stent. So then the angle changed. So then finally we can get across with the dilator and also finally press the stent across the distal bile duct obstruction. And this is, I did a recent review of the EUS-guided bleed drainage, including EUS-guided rendezvous with my ex-fellow, Dr. Koo Stanley from Malaysia. Now he's working with Professor Kielko, that we know him very well. So then about 5 studies thus far that recruited case with the EUS-guided rendezvous techniques. And highest number, certainly from our lecturer in this conference, Vinay Dear, our friend. So then that all cases of Vinay, he's done the procedure with the extrahepatic bile duct approach. And then the overall technical success is quite sky high. It's almost 100%. And the complication rate is really low. It's only 3%. And that, but for other folks like Takuchi Iwashita, done in the for extrahepatic duct approach and combined with intrahepatic duct approach, the overall technical success is only about 70%, and the adverse event rate is about 13%. And Iwashita did it again in 2016 with the all-case extrahepatic duct approach, and the overall technical success is only 80%, and the adverse event is about 15%. So Vinadia also did again both intra and extrahepatic duct, and the technical success is also sky high, but the adverse event rate increased from 3.4 to 23%. So look like that intrahepatic duct approach may be a little bit challenging than the extrahepatic approach in terms of the expert who done extrahepatic duct approach as well. But to my experience, I have very limited experience of extrahepatic duct approach. So this is the current data of study with the EUS-guided rendezvous. So then in this review as well, where is the rendezvous? So rendezvous will be in the at the low distal and high distal body obstruction, and without duodenal obstruction, that's the place of the rendezvous. So I like to end my lecture at this time, and thank very much for time listening to my lecture. Thank you.
Thank you, Dr. Pradhamche. And Dr. Rajesh, do we have time for a question?
Yes, sir, we have time.
Okay. So one question I would start off, and maybe Dr. Surinder and Dr. Sumit can follow if they have. Do you think that EUS rendezvous should be reserved for benign cases, and the rest you can do with antegrade stenting?
Actually, I think that the final outcome of rendezvous and antegrade stenting will be the same. We will have one stent, which is a transpapillary stent. So it doesn't matter malignant or benign case. But for benign case, probably I mean it's both. It's the final outcome will be the same. Yeah. So I think that there's no difference. The outcome will be the same with the RCP that we know very well. Yeah.
Dr. Pradhamche, very nice lecture. Just wanted to find out from you how frequently you're using a duodenal rendezvous in your practice now.
You mean extrahepatic duct approach, right?
Yeah, extrahepatic duodenal approach.
Frankly speaking, very rare in my institute. We mostly do intrahepatic duct approach because we start with the antegrade stenting because we want to save another scope for another procedure. So we just want to use one EUS scope to finish all procedure.
Yeah.
Dr. Sumit, do you have any question?
I had the same doubt that duodenal approach for rendezvous, is it because we find it technically very challenging to guide the guide wire if we are approaching it through the duodenum. So extrahepatic actually, intrahepatic route actually is easier to manipulate the wire.
I do agree. I do agree. Yeah.
Right. So can we shift to the next talk now?
Yeah,
thank you.
Yes, sir.
Okay.
I think
Surinder, can you please invite the next speaker?
If there are no more questions, thank you so much, Dr. Pradhamche. It was a pleasure listening to you. Hi, Dr. Amol, and he's going to speak on role of EUS in subepithelial lesions. Over to you, Dr. Amol.
Thank you, Surinder. Thank you, Pankaj. And I would like to take this opportunity to thank Dr. Sood and Rajesh for this excellent workshop and conference and for the invitation. So I'm going to discuss a little bit about role of EUS in subepithelial lesions. No disclosures. Let us start with the terminology. Should we call them subepithelial or submucosal? And I think subepithelial is a better terminology because submucosal means only from the submucosal layer, but intramural lesions may arise from any of the subepithelial lesions, layers of the GI wall. So to list out the subepithelial lesions at the beginning of my talk, so all of these are possible: cysts, leiomyomas, aberrant pancreas, lipoma, neuroendocrine tumors, or carcinoids, and so on and so forth. So I'm not going to just read them out. But let us start with the first point, whether, submucosal lesions, whether there's really mucosal or subepithelial, or whether they're extraluminal lesions. And we know that whenever we find these kind of bumps on endoscopy, not all of them are subepithelial lesions, and sometimes we may have liver, spleen, or so many other, even the gallbladder, and so many other normal organs which actually masquerade subepithelial lesion. And the role of EUS in these kind of situations becomes very useful, because EUS can be done in these situations, and EUS would definitely give us a diagnosis in majority of the situations, whereas the role of ultrasound or CT versus EUS is, where we compare that to ultrasound or CT scan, the difference is drastically very significant. So overall, the diagnostic accuracy of EUS, these are the studies which have been in the last 2 decades or so, till 2012, but the accuracy to diagnose lesions or tissue diagnosis has been around these, so ranging between 50% to around 82%. But then let us see the more recent literature, what it shows. So let us start with the aim. What is the aim when we perform an EUS for an subepithelial tumor or a subepithelial lesion? So the first thing is that we try and achieve a morphological diagnosis. Once we have that, then in certain situations we may also require to perform a tissue diagnosis. Then we also need to define the need for resection, and if the lesion needs to be resected, then the suitability for endoscopic resection. So these are the 4 questions that we usually try and address when we are performing the EUS. And when we try and do the EUS, what are the points that we try and look at? The first thing is that the layer of the origin of the lesion, whether it is arising from the submucosa or the muscularis propria layer or from the muscularis mucosa layer. Then the appearance on EUS and the echo texture, then the vascularity, whether the lesion is exophytic or endophytic, and then of course whether it is involving the adjacent organs or lymph nodes, and then we try and achieve a tissue diagnosis either by an aspiration cytology or a biopsy. So what is the choice of scope or probe that we have, linear, radial or mini probe? Well, this is one indication where probably a radial scope sometimes scores over a linear scope, at least in the initial evaluation of the lesion or the morphological evaluation of the lesion. However, lesions which are really small, less than 10 millimeters, it is preferable to use a mini probe, a high frequency mini probe, to scan these lesions, because doing that with the radial scope will also be difficult. However, lesions which are larger, more than 10 millimeters, can be tackled with a radial or a linear scope. However, we need to remember that we need to scan at a higher frequency so that the layer separation is better. And for layer demarcation and visualization of the complete lesion as well as morphological appearance, very often the radial scores over the linear scope. However, obviously we need to perform a linear EUS if we have to perform a tissue diagnosis. We need to perform a water immersion technique or a balloon inflation technique. Both these techniques have been reported. For gastric lesions or even for rectal lesions, we use a water immersion technique, whereas for esophageal lesions, because the water cannot stay there, usually a balloon inflation technique may have to be used. And smaller lesions are difficult to target, so we need to use a combination of endoscopy and EUS to localize and then scan these lesions. So what do we see? When we try and look at that, the first thing that we try and look at when we see a subepithelial tumor is we try and look for the transition zone, which will actually determine the layer of origin, then the size and echo pattern of the tumor, the border smoothness, internal features, echogenicity and vascularity, and then adjacent organs and lymphadenopathy. So this is a mini probe evaluation for gastric gist tumor, and you can see we first scan in the center and then on either sides where you can see the transition zone very clearly and the lesion arising from the muscularis propria layer. So it is very important to scan the transition zone. That is very important, because otherwise here we can see that the layers are quite indistinct in the first image, and because of that one may make a mistake, particularly if it is a larger lesion. So always look for the transition zone when we are performing the EUS. EUS also helps us for, when we are performing an endoscopic resection. Now, planning for an endoscopic resection, what we try and do is, now this is a lesion which is arising from the muscularis mucosa layer. Here you can see a muscularis mucosa layer lesion, whereas this is a lesion which is arising from the deep muscle layer or the muscularis propria layer. Now this is a leiomyoma. This is probably a granular cell tumor. Now this tumor can be treated very effectively by an ESD, whereas the leiomyoma from the muscularis propria layer would require either a full thickness resection or a tunneling endoscopic resection. So it is very important to differentiate the layer of origin so that we can plan the therapy better. Some common tumors which arise in the submucosa, carcinoids or neuroendocrine tumors, although they also arise in the mucosa or the they usually go up to the submucosal layer, although occasional involvement of or adherence to the muscularis propria layer may be found. Lipomas are typically submucosal, as well as ectopic pancreas, as well as varices and cysts are submucosal. And muscularis propria layers typically are leiomyomas or gastrointestinal stromal tumors, or neurogenic tumors like schwannoma or neurofibroma. Coming to the appearance, EUS appearance and ecotexture, we can see that anechoic structures are typically cysts, or they may be varices, and we can put Doppler and confirm whether it is a varix or a cyst. And hyperechoic lesion, particularly in the submucosal layer, would invariably be a lipoma. Now this is a classical diagnosis of a lipoma. There is no differential for this, and one can just leave that alone. It is the hypoechoic lesions which typically arise in the muscularis propria layer, which require further evaluation, because these may be leiomyomas or gist tumors. Now here the location of the tumor, whether in the esophagus or in the stomach, is very important, because in the esophagus they are typically leiomyomas, whereas when we come down to the stomach, they are more often gastrointestinal stromal tumors. However, this is not always the rule of a thumb, and very often hypoechoic lesions will require further evaluation in terms of tissue diagnosis. We will come to that in a moment. Further, regarding EUS appearance and ecotexture, now this is a classical ectopic pancreas, and further on a magnified view, we can see that it arises in the submucosal layer. It is an hypoechoic structure, and sometimes we will find some pancreatic tissue over there which with some ductal elements, which helps us to diagnose that. And this is typical appearance of varices that we can see over here on this image. Coming to cysts and evaluation of cysts, although we typically label cysts as anechoic, often they always invariably occur in the submucosal layer. What is important to understand is, although they are anechoic, layered contents can sometimes masquerade a solid lesion, as we can see on the left hand side over here. Now, this is a classical duplication cyst of the esophagus, and what is important, the reason why it's important for us to remember this is because we have to correlate with the other imaging as well, because if this is a cystic lesion, then we should at all times try and avoid needling of this lesion, because there is a significant risk of infection if we needle these lesions. Now, alternatively, here we can see a gastric duplication cyst, which is very clearly seen over here, and this is quite cystic. It is very easy to identify this as a cystic lesion. The next step is to choose the resection approach if at all the lesion demands resection, and Although surgical resection is the gold standard, endoscopic resection along with a laparoscopic approach is more and more getting popular, and it is applicable for lesions up to 5 centimeters in diameter. What is important to understand is exophytic lesions versus endophytic lesions. Now, typically A and B are endophytic, predominantly endophytic lesions, whereas C is mixed and D is predominantly an exophytic lesion. Now, A, B, C are usually amenable for endoscopic resection. However, D would not be typically amenable for endoscopic resection and would require surgery. What is also important to understand is type A and type B, we could get away with an endoscopic resection without a formal closure, whereas C will require a formal closure even if we want to do an endoscopic resection in these situations. Now, coming to the next step is EUS-FNA or FNAB for subepithelial lesions. So, do all subepithelial lesions require tissue diagnosis? Now, this is the question that we need to ask. The first question is, the first point is hyperechoic lesions in the submucosa. They are lipomas, no need for tissue diagnosis. Lesions which are less than 10 millimeters in diameter, no need for needling. Location in the esophagus, typically most often, even hypoechoic lesions deeper situated, most often they will not require a tissue diagnosis, although you may consider doing it depending on the appearance of the lesion, but most of them are going to be leiomyomas. Anechoic lesions, they are going to be either cysts or varices, and you don't want to be needling either of them, so no. And if the morphological appearance is typical, like for example an ectopic pancreas or something of that sort, then it may not be necessary to perform needling of these lesions. Hypoechoic lesions more than 10 millimeters, particularly from the muscularis propria layer, yes, these are the lesions which definitely require tissue diagnosis. And if an endoscopic resection is planned, there is an argument now which suggests that lesions between 1 to 3 centimeters in size, where if the ecotexture and the appearance, EUS appearance suggests that there is a possibility of malignancy or some sinister features, these lesions could be resected endoscopically and subjected to a complete histology rather than trying to perform a tissue diagnosis. Although this point could be debatable, it is definitely something that can be discussed about. Now, how do we perform a EUS-FNB? Now, most often we will need to perform a fine needle biopsy. Nowadays, with typically the newer FNB needles that are now available. So initially we perform a radial EUS for a morphological diagnosis, and this is a typical lesion from the deep muscle layer, and now we are performing an FNB. We use either of the FNB needles, either the Franzine or the Charcot or acquired needles or the Procore needles. Invariably we will require a core biopsy, and we will have to perform a fanning technique. I am not going to go into the technical details, these have been covered in other talks. The reason why we require a core biopsy is that immunohistochemistry is invariably required, and CKET and other IHC markers will be required for differentiation between the lesions in the muscularis propria, whether they are muscular in origin or neurogenic in origin, and whether they are benign or malignant. So that is the reason we need to perform that. Now, what is the yield of EUS-FNA or B? So this is typically a slide which was about 10 years ago, when predominantly everybody was using an FNA technique and aspiration cytology, and the mean accuracy was in the range of 60 to 90%. There is only one study which shows a true cut biopsy, all others are using FNA. But things have changed now. Now, with an EUS-FNA and an FNB, nowadays the sensitivity and the specificity using the true cut biopsies or the core biopsy needles or the FNB needles, nowadays the sensitivity, specificity and the positive and negative predictive value has increased significantly, and that is definitely a point to consider, that we need to possibly perform FNB whenever possible rather than an FNA. Now, just to list out some of the subepithelial lesions and the layer of origin. So the GIST tumors are typically from the 4th layer, rarely in the 2nd layer, and leiomyomas are from the 4th or the 2nd layer. Aberrant pancreas, 2nd, 3rd or 4th. Lipomas is always 3rd. Carcinoids, 2nd or 3rd layer. Granular cell tumors in the 2nd or 3rd layer. Cysts in the 3rd layer. Varices in the 3rd layer. Inflammatory or fibroid polyps in the 2nd or 3rd layer. Glomus tumors in the 3rd or the 4th layer. Lymphomas or metastatic lesions can be, going through all the layers. Typically, the lymphomas can also go through all the layers. These are the most common, which we need to differentiate very often. So, a suggested algorithm, and there are 2 algorithms which I am going to discuss. We perform an endoscopy with the detection of the subepithelial tumor, and EUS is the primary further examination for morphological appearance. And if there is a hypoechoic solid tumor below 1 centimeter or more than 1 centimeter, then we need to perform an EUS FNA. And if it's a GIST tumor, then probably surgical resection or chemotherapy using a tyrosine kinase inhibitor we need to perform. If it's a leiomyoma or a neural origin tumor, then follow-ups, and other lesions, then appropriate therapy may be required. Lesions less than 1 centimeter as well as lipomas or cysts can also only be followed up. They do not require a tissue diagnosis. And similarly, over here again, this is a similar algorithm, but they have also incorporated an endoscopy and biopsy, because sometimes epithelial malignancy can also present as a subepithelial lesion, and if we get a biopsy on that, then treatment has to be according to those guidelines. And the other difference in this algorithm is that they have kept as 2 centimeters as the cutoff point rather than the 1 centimeter for an FNA rather than, so this is again a debatable point whether 2 centimeters or 1 centimeter. I would still go by 1 centimeter, although lesions below 2 centimeter are quite difficult and challenging to target for an FNA and to try and get a yield for the FNA. So that is the point. So to conclude, I would like to say that EUS is definitely a mandatory investigation for evaluation of subepithelial lesions, and EUS morphology is important very often to characterize the subepithelial lesion. Layer of origin, EUS appearance and ecotexture can help characterization, and tissue diagnosis is necessary when characterization is not possible or when malignancy is suspected. Periodic EUS surveillance can be offered for suitable lesions that do not merit resection, and EUS can help plan resection either endoscopic or surgical, and anechoic lesions should not be biopsied as far as possible. So with that, I would like to thank you all for a patient hearing, and I'll be happy to take any questions. Thank you so much.
Thank you, Dr. Amol, for an excellent overview on this topic. I just had one question to you. This approach, would you say that the approach for submucosal lesions in esophagus and stomach versus the submucosal lesions in duodenum and rectum, the approach would remain the same, or you would change the approach for rectoduodenal submucosal lesions?
Well, Surinder, the thing is that majority of lesions are in the esophagus and the stomach. That is the reason I limited the discussion mainly to those lesions. But I agree that rectal lesions and duodenal lesions, neuroendocrine tumors are more often the pathology that we encounter, although we may encounter GIST tumors or something of that sort. Leiomyomas are quite rare, almost unknown probably in the rectum or in the duodenum. And neuroendocrine tumors as well as GIST tumors in these locations would probably merit resection. Now, when we are talking about neuroendocrine tumors, rectal neuroendocrine tumors definitely require resection. Duodenal, we need to characterize them, we need to do a chromogranin, we need to see a DOTA scan, and then probably decide whether they require surveillance or resection. So that I did not touch upon that topic because forget NETs, it becomes a topic of its own for a discussion. That would become a lecture on its own.
it's a huge topic, and it's an important message that rectoduodenal submucosal lesions you need to individualize. It's a different approach. And
Right.
where would you put contrast EUS in this management of say submucosal lesions in stomach and esophagus?
Right. So contrast is particularly if we are suspecting vascular lesions. So if we are suspecting a neuroendocrine tumor, then contrast would be useful. A GIST tumor also we would need to use contrast very often. And contrast is useful not only to characterize the lesion, but also to probably target our needle for an FNA when we are doing an FNA for a GIST lesion, because sometimes there may be anechoic lesion areas which are necrotic areas which do not actually come up on contrast, and you don't want to target those areas for the FNA. So that would be useful.
Thank you.
Okay, thank you, Amol, for that wonderful lecture. And can we now move ahead?
We can.
Hello?
We can.
Yeah, okay. And may I invite my first teacher of endosonography, Professor Mark Giovannini from Marseille, and he will be speaking on evolution and future of EUS-guided biliary drainage. Professor Giovannini, welcome.
Thank you.
And please go ahead with your talk.
Thank you. Thank you very much for this kind introduction, and thank you for the invitation. I'll try to show you what will be the evolution and the future, and also the problem that we have today with the EUS-guided biliary drainage. First of all, here you see the three technique: the choledochoduodenostomy, which is the direct puncture of the CBD at the level of the bulbus; the hepaticogastrostomy, which is the puncture of the segment 2 or segment 3 bile duct through the stomach with a special stent; and the anterograde stenting. But you speak about this technique previously. Just today, we need to discuss what is the place of the lamps for CDS, and the technique is of course easier because it's a direct puncture of the dilated duct, and it's easy to deploy the stent, and here you see to deploy the stent, and we have a nice drainage of the bile into the duodenum. But today there is a discussion on the risk of this technique in comparison with the standard RCP, and we will see this after in my presentation. This is the video of an anterograde stenting. Anterograde stenting is very useful if you fail to cannulate, but with a normal anatomy, a normal papilla, because it's easy to deploy the stent, and after, if the stent is occluded, it's easy to come back with a duodenoscope. The only thing is to know where is the papilla, and the trick is to push the stent into the duodenum, and after to pull back. And when you have the resistance, we can deploy completely the stent into the bile duct. The hepaticogastrostomy, today we use a new second generation of stent. We see the Jobor stent. Yeah, this is the technique, and you know the first step is the puncture of the duct. Today we can also perform this technique even if the ducts are not so dilated, like in this case. And now we use the a 19 gauge needle with a 25 guide wire, and this is the opacification. This patient has a duodenal obstruction and with a previous stent. And the goal of this procedure is to achieve an hepaticogastrostomy, and we will use for this technique the last generation of Jobor stent, which is a 3 centimeter uncovered, and the first generation has a 50% uncovered. And this 3 centimeter, it's enough to anchor the stent into the bile duct, and the long part, the 70% covered, they prevent the bile leakage. And this is this new design of the second generation of Jobor stent, that they reduce the risk of bile leakage, which is one of the main complication of the EUS-guided biliary drainage. But the future, it's the evolution of this stent with a combination of the lamps, the Spaxus with the Jobor, and this is this new stent here, and you see it with the head, the part inside the stomach will be like the Spaxus stent, with also a direct access and not access, and we don't need to use the cystostome, and the cystostome will be included into the delivery system, and we can pass directly on the wire into the bile duct and to deliver this new stent. And this design will reduce the number of manipulation. And of course, if you reduce the number of manipulation, we will reduce the risk of complication. There is for different clinical situation, and for malignant stenosis of the CBD, you know that now we have a good safety of choledochorioidenostomy, and the pool rate of adverse event is reduced, less than 15%. And it seems in this paper that on the subgroup analysis using the lamps, the adverse event, the rate of adverse event was lower. PTBD, there is no discussion. Today, the USBD has replaced the PTBD because USBD is associated with a better clinical success, fewer post-procedural adverse events, and low rate of reintervention. Safety of US choledochostomy using lamps, I speak about this. And you see 3 recent papers, and one from France. And you see that the percentage of complication is reduced, is less than 7% in this study, this different study. The only problem is the late dysfunction and maybe the food impaction, sorry. In this 3 paper, the percentage of late dysfunction was less than 20%. In other study with a longer follow-up, it's around 30%. Choledocho or hepatico, you see there is no difference in terms of success, clinical success, technical success. Only one study, the study from Europe, showed that there is a little bit more complication if you perform an hepatico-gastrostomy than the CDS. But today with the new stent, I'm not sure that this is really true. The burning question is EUS-guided biliary drainage can replace the conventional transpapillary ORCP in patients with a malignant disease of the lower part of the CBD, mainly pancreatic cancer. You see there is these 3 papers. Everybody knows that these 3 papers published 3 years ago now. There is no difference in terms on clinical success. It seems that the stent patency was better for the EUS route, and also in terms of adverse event. Of course, there is no post-procedure pancreatitis if you use the EUS route. But in terms of adverse event, 2 of the 3 studies show less adverse event if you use the EUS route. But the problem in this, you see on this meta-analysis, and I think the only problem is the type of complication. And today, the bile peritonitis, which is the main complication of the EUS route, is more severe in the US group. than the complication that we have using the RCP, the conventional RCP route. And this is the discussion, and of course, we cannot accept to have such complication in patients with advanced pancreatic cancer, and probably the future should be to have a very safer stent deployment for the CTS to reduce to zero the risk of bile peritonitis. Benign stenosis, and benign stenosis is very interesting because this is probably a new development of the use of EUS. Not like in this case, because this was a patient. It was not possible to cannulate the papilla because the papilla was into a diverticulum, and this is and you see a rendezvous. You did a nice presentation on the rendezvous technique, and with the direct puncture of the CBD and injection of contrast, and after the insertion of the wire, and the wire will pass into the duodenum, and we will exchange the scope for. More interesting is that the patient with an altered anatomy. The patient with altered anatomy who develop a stone, or patient in which it was very difficult to access, and or patient with stenosis after Whipple resection, stenosis of the biliary jejunal anastomosis. And the US today can replace the external, the PTC calibrage of this anastomos, or the PTC treatment of stone in this patient with altered anatomy. This is the two studies published in the literature, and you see this is a Japanese, this is our study with quite a good technical and clinical success. Just to show you some example. This is a patient with a stenosis of the hepatico-jejunal anastomosis after Whipple resection. And you see the first step is to do an hepatico-gastrostomy using a fully covered stent. And this stent is protected by a double pigtail. The double pigtail pass here the anastomosis. And we leave this during 2-3 weeks. And after 2-3 weeks, we can come back. We can remove the metallic stent. And after, by this new access to the bile duct, is possible to do a dilation of the anastomosis and to insert multiple double pigtail stent to do the calibration. And we can do the same for stone. In case of stone like this here, you see that this is the stone. We can do with the spyglass the litho 3C and the destruction of this stone in this patient with an altered anatomy after partial gastric gastrectomy. Malignant hilar stricture. This is interesting also. Is probably a new development of the US biliary drainage. Is the combination of the drainage of the bile duct using the ERCP and the US. And ERCP and US are not enemy; they are a friend. And this is probably one of the best indication. And the second question is how to drain the right lobe with the US, and you will see that it's today possible. And this is the typical case of a patient in which the right lobe was drained using the endoscopic route, and the left lobe was drained because it was not possible to assess endoscopically by ERCP the left duct by US, and you have this kind of drainage. More difficult, here you see a type 4 with 3 stents inserted endoscopically, and the left lobe drained using the US route. Here you see this complete drainage of this huge cholangiocarcinoma with 4 stents, 1, 2, 3, and 4. And it's very important to have a complete drainage if you want to treat this patient by chemotherapy or radiochemotherapy, because if you leave one segment or 1 or 2 segments not drained, there is a high risk that the patient develop hepatic abscess or cholangitis during the treatment. And this is very complex with 2 hepaticogastrostomy for this patient, and also 2 or 3 stents in the right lobe inserted endoscopically, or like this also with this very infiltrative cholangiocarcinoma. To drain the right lobe, you have the hepaticoduodenostomy, which is not so easy. And I prefer for the bridging technique. I will show you the video. This is a patient with a type 2. It was with an altered anatomy. The patient has a partial gastrectomy previously for benign disease. He developed a cholangiocarcinoma. And we decided to do the drainage using the EUS route. And the first step is the puncture of the segment 2 or segment 3. This is the segment 3. And this is the opacification with after the insertion of the wire. This is the cystostome, and the cystostome is very, very important in this procedure. We can manipulate the wire. This is a G wire, and we with the manipulation of the wire, we can pass into the right lobe, and you see we can insert deeply the wire, and with the cystostome we can create a channel through the tumor with the pure cutting current, and we insert deeply the cystostome in the right lobe, and we can inject, of course, with the cystostome, which is very important, and we confirm the good position of the cystostome here, and here you see the stenosis. And the next step is to do a dilation with a 4 millimeter balloon of this stenosis here, and after we decide to insert the first stent. The first stent should be an uncovered stent of 6 or 4 centimeters, depends on the anatomy of the patient. This is a 6 centimeter. And the goal of this stent is to do a communication between the right and the left lobe. And after, the left lobe will be drained into the stomach using a Gilbert stent. Here you see the opening of the uncovered stent to achieve the communication between the right and the left lobe. And after, it's like an hepaticogastrostomy. Here you see the Gilbert stent into the stomach, and you will see the final results. And this is the final results with a complete drainage of the liver, the right lobe into the left and the left into the stomach. In the literature, there is 25 patients are treated using this bridge technique as today, and you see the paper from Ogura from Japan, and this is our study, and with clinical success, it was around 80%, with a morbidity rate of 33%. But what is important, this is a paper that we have published 2 years ago now in European Gastroenterology Journal. And the goal was to, in patients with malignant stenosis of the hilar area, including cholangiocarcinoma and metastasis, mainly from breast and colon cancer, and to know what is the percentage of segment liver drain needed. And you see, you need to have more than 80% of liver, and this, when you have more than 80%, the patient has a better survival rate. And also for this patient, 73% of this patient can receive after the drainage a new chemotherapy or a new treatment. And what is important to obtain this drainage, we have combined all the technique that we know. We have combined the RCP, the PTBD, and the EUS, and to achieve the complete drainage of this very complex stenosis. And I think this is quite new, and we need, and for this reason that for the future, the young endoscopist and the young gastroenterologist should learn ERCP and EUS in parallel. And this is our decisional tree in case of failure of ERCP. Duodenal lumen is intact, choledochondroidenostomy or anterograde stenting, altered anatomy or duodenal obstruction, hepatico-gastrostomy. Thank you very much for your attention, and I await your question.
Very good.
Yeah, thank you, Professor. That was an excellent talk. And do we have time for questions, or the time is up?
Yes, sir, we have.
We have 2 minutes.
Okay, Dr. Sumit, if you have any question, Dr. Surinder.
No questions, no, but this was most inspiring, Professor Mark. I have some doubts. Actually, when we are doing these procedures, the most common difficulty which we face is the right accessories. So especially when we are exchanging accessories after the guide wire has gone in, sometimes during the balloon insertion for dilation, the bile duct or the duct is pushed away, and then we end up losing the entire procedure, or we have to switch over to the endoscopic view. Any tips for or any good accessory which you feel that will reduce this kind of a complication?
You speak about the drainage of the right lobe with the EUS?
No, I speak about the regular biliary access via EUS.
Right, the choledochondroidenostomy or
yes.
the hepatico-gastrostomy?
Choledochondroidenostomy.
Choledochondroidenostomy, I think if you if you use the orthaxios, it's better not to put before a wire, because if you insert a wire, after you have this problem that you will push the CBD, and you cannot enter with the stent. It's better not to use the wire. After, if you use you do the puncture with the wire, after you need to use a cystostome, because the balloon is very difficult to pass the balloon if you don't use the cystostome. And for us, the cystostome is mandatory for hepatico-gastrostomy and for choledochondroidenostomy if we don't use orthaxios or oxpaxus. After, for the hepatico-gastrostomy, I don't like to delay it. I use the cystostome, and after I insert the stent with no dilatation. And I use mainly a wire which is a rigid wire also. But I think that the main accessory for me is the cystostome, the 6-French cystostome.
Right. And the stent which you showed with the hot tip geobore will reduce.
I hope this is not available. I just see the prototype, and it's not available in Europe. I know that they start to use in Korea. It's Professor Moon is an evaluation for this stent. I don't know if Praderm has experience with this stent, but I think this could be a good solution to your problem and also for my problem.
That's more like a 21st century device for a 21st century procedure.
That's right. I think so.
Thank you, sir.
Right. So I think I take this opportunity to thank Professor Mark, Amol, and Dr. Pradamche for wonderful talks and the discussion, and my co-chairs, Professor Surinder Rana and Dr. Sumit. And it's very good to see you, Manuel, also after such a long time, and hope to see you soon, everyone. Thank you all for a wonderful session, and probably we can move on to the next session now. Thank you for sticking on to the time, all of you.
Thank you.
Fantastic.
Wonderful talk, Mark and Emil.
Thank you very much for that wonderful session.